everyone. My name is Ibi Dagogo Jack. I'm a thoracic oncologist at Mass General Hospital, and welcome to OncTalk 2024. I noticed some of the programming may have said 2023, but we're excited to be in 2024 now. I think we have a very exciting program. We have 4 speakers and kind of just a run of show. We're going to have 2 talks. The first are about early stage lung cancer. Then we're going to have a panel afterwards. Then we're going to focus on 2 talks, I think very exciting topics, radiation for stage 4 lung cancer, as well as kind of thinking beyond chemo, immunotherapy, and targeted therapies. And then a panel after, and then we'll take some questions and answers, and then we'll wrap up the program. So thank you again for joining from wherever you are. We look forward to this program. And so for the first talk, it will be given by Dr. Millie Das. Dr. Das is, by way of introduction, she specializes, so everyone here, I think it's an exciting panel because everyone here specializes in thoracic cancers. We have medical oncologists, we have thoracic surgeons, and we have radiation oncologists. So very much multidisciplinary, and that really is reflective of how we practice. And so Dr. Das, she treats patients at Stanford Cancer Center as well as the VA, Palo Alto VA. So I think a very unique perspective there. And so Dr. Das is going to be speaking to us about updates on perioperative therapies for resectable lung cancer. So a mouthful, and hopefully we'll get that distilled down into kind of the salient elements. So I'll turn it over to you now.
Thanks so much, Dr. Dagogo Jack. I'm going to share my screen and my slides. Right. Is everyone able to view the presentation? So it's really an honor to be here as part of this really esteemed group of practicing oncologists, radiation oncologists, and I'm thrilled to be able to speak about perioperative therapies. This has been a very hot topic in the field of lung cancer. And so I'm really going to try to go through some of the recent trials that have been completed and some of the data that we have so far, and sort of time to go over some unanswered questions and certainly take any questions that may arise. Right. Disclosures are listed here. All right, so this is just a brief agenda. I will be talking about the major trials in the neoadjuvant, perioperative, and adjuvant space, and just go into some detail on these trials, and then we'll end with some sort of conclusions or remaining questions. So to start with in the neoadjuvant space, I think the major trial here is the Checkmate 816 study. This is neoadjuvant nivolumab plus chemotherapy. So this was a randomized phase 3 trial involving patients with stages 1B through 3A non-small cell lung cancer according to the 7th edition TNM staging. These patients had to have a good performance status and no known sensitizing EGFR or ALK alterations. You can see that they were stratified according to stage and PD-L1 status as well as gender, randomized 1-to-1 to receive either standard of care neoadjuvant chemotherapy given every 3 weeks for 3 cycles, or the experimental arm was chemotherapy plus nivolumab, the PD-1 inhibitor, given IV every 3 weeks for 3 cycles. Patients in both treatment arms went on to receive surgery within 6 weeks, and then there was an optional adjuvant chemo plus or minus radiation for those patients who were felt to warrant that additional therapy after the time of surgery. But really, this trial was looking at neoadjuvant nivo plus chemo, and the question here really wasn't more on the adjuvant space. It was neoadjuvant. Notably, in this study, 63% of the patients had stage 3A disease, and 50% of the patients had a PD-L1 of greater than or equal to 1. And so this is the event-free survival and the intention to treat patient population. You can see here that patients who received the addition of nivolumab to chemotherapy neoadjuvantly did better compared to those patients who received chemotherapy alone. And this is with regard to event-free survival. When the nivolumab was added neoadjuvantly, the pathologic complete response rate was 24%, which was significantly higher than those patients who just got chemo. And then the major pathologic response was 37% with the addition of nivolumab. So this is looking at checkmate the event-free survival and OS in the PD-L1 positive subgroup of patients. So remember that 50% of the patients were PD-L1 positive, and you can see here a more striking benefit with the addition of nivolumab, with both regard to EFS, event-free survival, and OS, overall survival. For EFS, you see the hazard ratio of 0.46, clear separation of the curves in favor of those patients getting neoadjuvant nivo plus chemo. And then OS, also you're seeing a real clear separation of the curves, hazard ratio of 0.37. So these are really the patients, the PD-L1 positive patients are really the ones that seem to be driving the greatest benefit. All right, moving now on to the perioperative space. And there have been a number of trials that have been recently completed. And so I'll go through each of these. So the Aegean trial is looking at perioperative durvalumab. So durvalumab is a PD-L1 antibody. You can see here, this trial involved treatment naive, good performance status patients with resectable stages 2A through 3B disease, which included N2 positive disease according to the AJCC 8th edition. These patients had to have a planned lobectomy, sleeve resection, or bilobectomy as part of their surgery. They had to have tissue confirmation of PD-L1 status. And again, this study excluded patients with EGFR and ALK alterations. Patients were randomized to receive either platinum-based chemo plus placebo, given IV every 3-4 cycles, or the experimental arm was patients receiving platinum-based chemo plus durvalumab, given IV for every 3 weeks for 4 cycles. So you can already see in the neoadjuvant setting here, it's 4 cycles as opposed to the 3 cycles that was administered in Checkmate 816. Patients in both arms went on to receive surgery. And then there was an adjuvant portion of this trial. In the experimental arm, patients went on to receive additional durvalumab given IV every 4 weeks for an additional 12 cycles versus placebo. And this is the event-free survival from Aegean, showing that the patients receiving the addition of durvalumab did do better compared to placebo, stratified hazard ratio of 0.68. Patients who received durvalumab had a pathologic complete response rate of 17% and a major pathologic response of 33%. Next is the Keynote 671 study. This is perioperative pembrolizumab, which is the PD-1 inhibitor. So again, these are patients with pathologically confirmed stages 2 through 3B disease per the AJCC version 8, no prior therapy. These patients have to be undergoing surgery with a tumor sample available for PD-L1 analysis. They were randomized in this trial to get chemo plus placebo versus chemo plus pembrolizumab, given IV every 3 weeks for up to 4 cycles. Patients in both arms went on to receive surgery. And then again, there was an adjuvant portion in the experimental arm. Patients went on to receive additional pembrolizumab, given IV every 3 weeks for up to 13 cycles versus placebo. This is the event-free survival from Keynote 671, showing that the patients receiving pembrolizumab did better than those who did not, compared to the placebo. So you're seeing hazard ratio of 0.58. Pathologic complete response is seen in 18% of patients receiving pembrolizumab, and a major pathologic response is seen in 30% of patients receiving pembrolizumab. This is the OS data that we have to date, where you are seeing some separation of the curves in favor of those patients getting pembrolizumab, hazard ratio 0.72. We also have the NeoTorch study. So this is looking at perioperative toripalimab. So this is a PD-1 inhibitor that we're not really using in the US, but it's being used elsewhere in Asia. So this trial was conducted in Asia. This was involving newly diagnosed stages 2 through 3 non-small cell lung cancer patients, again, EGFR ALK wild type. And you can see that they're randomized kind of similarly to the other trials. In this perioperative trial, the neoadjuvant portion was given for 3 cycles as opposed to the Aegean and the Keynote 671, where it was given for 4 cycles. So again, it was platinum-based chemo plus toripalimab, IV every 3 weeks for 3 cycles. This was a placebo-controlled trial. Patients went on to receive surgery. And then there was this additional adjuvant portion. Interestingly, in this study, There was one adjuvant cycle of toripalimab, again, plus platinum-based chemotherapy. And then after that was the maintenance immunotherapy, the toripalimab given IV every 3 weeks for up to 13 cycles. So I would say the study design is a little bit different from what I just showed you. And I think it's just notable, really, for the fact that the neoadjuvant 3 cycles as opposed to 4, and then this additional adjuvant platinum-based chemo plus toripalimab cycle that was given after surgery. In this study, notably, the majority of patients, 66% of patients, had PD-L1 positivity, and 78% of patients had squamous histology. So this was definitely a little bit different, again, from some of the other studies where we're seeing an overrepresentation of squamous histology. And this is the event-free survival, and you can see here that the patients receiving toripalimab did better with regard to EFS with a hazard ratio of 0.40. We also have the Checkmate 77T study, which is perioperative nivolumab. So again, Checkmate 816 was neoadjuvant nivolumab. This is perioperative nivolumab. So very similar study design, I think, to the AGN and the Keynote 671, where patients are getting, again, these are stages 2A through 3B disease, no EGFR ALK, randomized to getting placebo plus chemo versus nivolumab plus chemo. In this perioperative trial, it was 4 cycles neoadjuvantly, patients going to get surgery, and then additional nivolumab for a year. And you can see event-free survival favors those patients getting nivo plus chemo, and pathologic complete response seen in 25%, major pathologic response 35%, hazard ratio of 0.58. All right. So that was sort of a whirlwind through the perioperative trials. I'm going to end with the adjuvant trials. The first is the Empower-010 trial. This is adjuvant atezolizumab, the PD-L1 inhibitor. So again, this was only looking in the adjuvant space. So these are patients who've already undergone surgery for their early stage lung cancer. So stages 1B through 3A non-small cell lung cancer patients were included, with 1B tumors being greater than or equal to 4 centimeters. They had to have had a lobectomy, and they had to have tumor tissue available for PD-L1 analysis. Patients go on to receive standard of care cisplatin-based adjuvant chemo given for 1 to 4 cycles, and then we're randomized to getting either best supportive care or atezolizumab for a year. And you can see here that the disease-free survival favored those patients getting atezolizumab, specifically in the PD-L1 positive stage 2 to 3A population, where the hazard ratio was 0.66. When we look at the OS data, you can see here specifically the OS in the PD-L1 greater than or equal to 50%, stage 2 to 3A patient population. You're seeing a clear separation of the curves in favor of those patients getting adjuvant atezolizumab. And so this is really, I think, consistent with what we know about immunotherapy, where we're seeing sort of higher responses, greater benefit in the patients who have high degrees of PD-L1 expression. In fact, if you look here on the left, the patients who don't have PD-L1 expression, these patients do not really seem to be benefiting from the adjuvant atezolizumab. We also have the Keynote 091 adjuvant pembrolizumab study. So similar study, again, completely resected early stage lung cancer, stages 1B through 3A patients were included. And you can see here patients went on to get adjuvant chemotherapy that was part of standard of care, limited to less than or equal to 4 cycles, and then were randomized in this study to either pembrolizumab versus placebo for about a year. And this is the data from the Keynote 091 study. We look at the disease-free survival first on the left. Overall, in the overall population, hazard ratio was 0.76 in favor of those patients getting adjuvant pembrolizumab. When you look specifically in the middle here for patients with high PD-L1 status defined as greater than or equal to 50%, you're seeing some overlap of the curves. And I'll mention that this is somewhat, I think, confusing finding because it's not really consistent with what we know about immunotherapy being more efficacious in the high PD-L1 patients. And so I think there's a lot of sort of head scratching about this particular result where we're not seeing that clear benefit of pembrolizumab in the high PD-L1 patient subgroup. In the overall patient population, you can see not statistically significant, the curves kind of coming together. So I think remaining questions and controversies from the data that I've just shared with you are operative approaches. So this is the pre-op and the post-op treatment. Is this superior to pre-op only, so neoadjuvant only, or post-op only, adjuvant only? which patients require additional therapy after neoadjuvant chemo IO? I think that's one of the big questions remains in the field. How much therapy is needed? I shared with you the different trials. You'll notice that the studies are somewhat heterogeneous in terms of the number of cycles administered, some of the stage subsets that were included, the treatment regimens, the biomarker subsets. And so I think, sometimes when we see these heterogeneous trials, it's hard to really make out, which of these is really the best strategy. Are there ways that we can think about these different drugs and different study designs to really try to apply these to the patients that we're seeing in our clinics? What is the role of pathologic response in determining long-term outcomes? So this is, of course, looking at pathologic complete responses versus major pathologic responses. So should we be looking at that in order to determine who requires additional therapy? And then finally, is there a role for circulating tumor DNA for individualizing treatment decisions? I think there's a lot of hope in this, but I think we're just not ready right now for prime time and for using these assays in the clinical setting. This is just my last slide, just to show some data from one of my colleagues at Stanford, Dr. Max Dean, who has really been looking a lot into circulating tumor DNA and using this as a marker of whether patients are going to have disease recurrence or progression. And so you can see here in this interesting study, patients with localized lung cancer who were treated definitively with either radiation or surgery plus or minus chemo had a minimal residual disease or MRD testing done after their treatment. And so this was ctDNA quantification. And you can see the patients who had no ctDNA detected at this MRD landmark did quite well. So they really didn't have disease progression versus those patients who did have ctDNA detected at the MRD landmark. So this really provides proof of concept of using this potentially in the clinic, though, I think we're still trying to propose trials and really try to incorporate this to see whether we can alter outcomes for our patients by potentially using this as a marker for who will require additional therapy. Thank you so much for your attention.
Thanks so much, Dr. Das. Sorry, I'm having a little bit of difficulty restarting my video, but I'm happy to introduce Dr. Yang. So Dr. Yang works with me here at Mass General Hospital. He's a thoracic surgeon. Dr. Yang has trained kind of throughout the US, so it's excellent. So he's been in Boston, he's been in Stanford, he's been at Duke, and so offering a lot of perspective across the board. And so Dr. Yang will be discussing surgery for lung cancer, the types of surgeries, what are the considerations that go into determining what type of surgery and when to offer surgery. So with that, I will turn it over to you.
Great. Thank you so much for the invitation to speak with you today. And I'm really excited for this opportunity to share some more information about lung cancer surgery with you. So we'll get started and really focus on different types of lung cancer surgery. But before surgery, there are some considerations. And one is that we want folks to be able to do well after surgery. And in order to do so, it's really important to pay attention to lung function, to heart function, to how active a patient is. And that is so that after surgery, we generally want patients up and walking 3 times a day, the day after surgery, sometimes even the day of surgery, so that they could take deep breaths and feel comfortable and not have pneumonia and other complications afterwards. So that's a really big consideration. And then in terms of, we always want to make sure for early stage lung cancers to still do a thorough workup and check to see if there's any disease in other parts of the body so that we don't put a patient through unnecessary operation. I think it's really exciting that early stage lung cancer is curable. These are survival curves from the International Association for the Study of Lung Cancer, looking at how well people do after surgery. And if you look at these 3 columns here, first, which is the earliest stage lung cancer, which in the era of lung cancer screening and more CT scans detected and more CT scans being given to folks for different kinds of workup and earlier detection of lung cancer, there's a lot more people with earliest stage lung cancer. And you can see that the 5-year survival rate is phenomenal. It's 80 to 90%, meaning that if you look at 100 people, 80 to 90 people with early stage lung cancer will still be alive after 5 years after surgery. These are the different types of lung cancer resection. So a wedge resection is where you only take out a slice of the lung. I've heard it be described as taking a bite out of an orange, so to speak. And segmental resection is when you take more of the lung and you really focus on dissecting out the artery, vein, and the bronchus, and it's what we call an anatomic lung resection. And the analogy, I've also heard it, the analogy I've heard being used is it's like if you look at an orange, you're taking a full slice of the lung. So not just a bite out of the lung, but actually a full slice. So something that makes anatomic sense and is a full compartment. And then lobectomy is where so everybody has 3 lobes on the right side. So the lung is split into 3 lobes on the right side and then 2 on the left. And a lobectomy is when you take out an entire lobe of the lung. So diving a little bit deeper into the different lobes. So this is the right upper lobe in purple on this where my cursor is, and then the middle lobe and the lower lobe. The middle lobe is the smallest of the lobes, and then the left upper lobe and the left lower lobe are on the left side. And then this is split further into these different segments as we were talking about earlier. So sometimes if, for example, if a patient has a tumor right here at the tip, you could just take out the part in the green as opposed to taking out the entire lobe. And likewise, I practice what are called complex anatomic lung resection. So it is hard, for example, to just take out level 7. It's hard to just take out segment 7 or just segment 8, but that's something that our field is trying to do in light of smaller and smaller lung cancers. So going back to specifically each type of operation, a wedge resection is when you remove a wedge of lung containing the tumor along with a rim or a margin of normal lung. And the advantage to a wedge resection is that it has the quickest lung cancer operation. It is when only a tiny bit of lung is removed, and usually you're only in the hospital for 1 day with a relatively rapid recovery at home. And the disadvantage to that is it's only although we do always practice taking out lymph nodes. In fact, our standard guidelines, which we follow, are to take out 3 mediastinal lymph nodes, which are lymph nodes in the middle of the chest, and 1 hilar lymph node, which is a lymph node a little bit farther away from the middle of the chest, but still closer to the heart. Even though we always do that for the wedge, there are still smaller and smaller lymph nodes that you don't necessarily get with a wedge resection. This is what a wedge resection can look like. This is the lung. This is basically an inside view where you have the camera in there, and then these are the ribs in the chest wall. And imagine there's a cancer right here, and then you fire a stapler, and then you take out this little bit of lung. This is what it looks like in the actual operating room. This is a robotic arm, so this is a robotic wedge resection right here, and then just a tiny snippet of lung is taken out. For a segmentectomy, you remove 1 or more bronchopulmonary segments that we talked about, the little different tiny compartments that comprise a lobe. And the advantages to a segmentectomy is that it preserves lung tissue, and it offers a good lymph node dissection. You could take more lymph nodes. And the disadvantages is that there are slightly more increased risk of prolonged air leak from the lung surface. So after surgery, sometimes the lung gets irritated and leaks lung, and with the segment, you can have more of that. And it's a longer operation. It definitely takes longer because, as I mentioned earlier, it's one of the hardest operations that we do because it's harder to tease out the different anatomic lung structures. So this is a picture that I showed earlier. Let's imagine that the tumor is in here. It's in one of the apical segments at the top, and then you could see that there's a tumor here, and then this tumor is, there is a particular airway, which is in white, a little blood vessel, which is an arterial branch, and a venous branch that are going into that particular lesion. And you can, if you want to just take this part out, but do it in a way that also isolates the blood vessels and the airway, you could do a segmentectomy. This is, for example, example of controlling the pulmonary artery before you take out the lesion. And then afterwards, you fire off the stapler and you divide the lung tissue, but then you also end up dividing the airway, the arterial, and the venous branches to that particular segment. A lobectomy is what has been traditionally the classic operation that has been done most commonly for early stage lung cancer. And this is when you remove the lobe of the lung. And the advantage is that it offers the most complete resection and best lymph node dissection, but it does have a larger impact on breathing after the operation due to more lung tissue that is removed and more normal lung tissue that's removed. If you see here, this is what a lobectomy would look like in these general diagrams. So, for example, this is the right upper lobe, middle lobe, lower lobe. And in order to take one of these lobes, you really gotta isolate all these different branches of the artery, the vein, and the bronchus. And so I'll walk you through some of the anatomy. This is the one of the trunks going off of the pulmonary artery into the lobe, and then this is the basilar trunk, segmental trunk, and then you have lymph nodes right here, for example, station 11. And then here on the right, in order to take this right upper lobe, you gotta make sure you get this airway. This is a airway branch going into the right upper lobe, and so this is dissecting and isolating that. And then after you divide that, there are some more lymph nodes that you take. So just a few pictures. This is not the complete. These are not the complete steps of the lobectomy, but it gives you a sense of what goes on with the lobectomy. As you continue going through, you do have to, after you've divided the airway and the different branches, so this is arterial and the venous branches, you then do have to divide the lung tissue right here in order to separate this out. And then this is an example of what it looks like in the operating room, where this is the right lower lobe, right upper lobe. This is a branch from the artery into the right upper lobe, and this is the airway branch there. This is the azygous vein that we don't touch, and then this is the chest wall. So one thing that we pay special attention to is lymph node dissection. I think lymph node dissection is really important, and this is a map of the lymph nodes. It's important because you can see if there's any microscopic tiny disease in the lymph nodes if you take them out under the microscope. And if that's the case, then you have different types of treatment and medicine you give that Dr. Das has talked about, and I'm sure we'll be discussing later on today. And so it's a different treatment pathway, and that's why surgery and getting out these lymph nodes is important, to truly figure out what is the best for the patient. And these are different lymph nodes at different areas of the body. But I'll just briefly walk you through. This is the main airway called the trachea, and then the airway going in the right lung, airway going into the left lung, and then you see that there are these different lymph nodes that are everywhere. I had previously mentioned we always try to get 3 mediastinal lymph nodes. So usually, for example, on the right side, we get the lymph nodes here in blue, in orange, and also here in pink, and also here in green, in order to do a thorough lymph node dissection. Lymph node dissection is an essential part of most cancer operations, and that's because the PET scan can be wrong 10 to 15% of the time. And as I mentioned, if you get the accurate lymph node information, that can lead to different treatment regimens. And lung cancer staging depends in part on the location rather than the number of lymph nodes involved. And that's why we try to take different stations in different locations of the lymph nodes. So these are some pictures of lymph node dissection. This is what some lymph nodes look like. And this is in the 2R, 4R area for the right upper lobe. And so just walk you through some of the anatomy. This is the superior vena cava, this where the body gets blood that has no oxygen into the heart, and then the vein draining it. As it gets vein draining in, and then we have the lymph nodes right here that folks will try to take out. After you take out a picture on the right, you see it's all completely clean. The lymph nodes are all gone. This is the airway, and this is the lung. So that is generally what we try to do with these operations. So I've told you all these different operations, and you might be wondering, when do you do which one? So traditionally, lobectomy was the operation of choice for lung cancer because of improved survival over limited resection from a study that was published in 1994. And that was thought of for tumors 3 centimeters or smaller, and if there was no disease elsewhere. But recent research, these are actually 2 randomized trials in Japan and in the United States, show that there's no difference between taking a lesser piece of lung versus a bigger piece of lung. And so these are survival curves. The way to interpret these survival curves is every time these survival curves dip down, that means a patient has unfortunately passed away. And the x-axis is the years. And so you can see that the blue line is lobectomy, the red line is segmentectomy, and it's very close. It's closely overlapped. And in here, the 2 lines are completely overlapped. So no difference in survival between these 2 types of operations. And some considerations that we have these days is, I think generally folks try to do lesser lung cancer operations if it's smaller and along the edge of the lung. This is a CT scan. This is the right part of the chest. This is the lung, and this is the edge of the lung. And you can see the lung cancer right here at the edge of the lung. And other considerations for how much you would take is if a patient can't tolerate, if the patient's lung function is not good to begin with, you really want to try to take lesser lung. And then if they previously had a surgery in the past, then you would also try to take smaller pieces of lung. And if you think that maybe they might need to get surgery in a future date, then you would also try to take smaller pieces of lung. So this is something in the periphery. Now this is something right in the middle of the lung, of the right upper lobe. And in that case, it might be hard to actually take out the entire, just an entire segment or a wedge, because it's so in the middle of the lung. And that's when you would consider a lobectomy. And then the approach that's commonly used now in 2024. So I practice both VATS and robotic, which I'll briefly explain. So basically, these are just small incisions. Oftentimes, I actually just use 1 incision these days, especially for smaller operations. But I would say 3 ports is very standard, where you have a camera in 1 port, and then you have your instruments in these other small ports to take out the lung. And so this is a diagram of the chest wall and where the ports are and where the instruments are. And this is a picture of what it would look like when you have these instruments going in there. And then these are what the instruments look like right there. In terms of for robotic approach, this is a increasingly adopted approach using the robot. Even though it's called the robot, which is what is looked like right here, it's still a person using the robot and telling the robot what to do. And the robot allows for, I would say, a really high definition camera so that you can see things really up close, and then also allows different angles of the instrument. Studies have shown that both robot and VATS are equally good for lung cancer, especially early stage. So if your surgeon does VATS, that's great. If your surgeon does robot, that's great. And you don't have to worry too much about whether they're doing robot or VATS. Because I know sometimes people think that the robot, it sounds very futuristic and cool, but really the robot is the same as VATS. So it's just a matter of what the surgeon is comfortable with and how they were trained on. But basically with minimally invasive operations, the reason why people do really well after the operation compared to before is this is open thoracotomy, where you have to make a big cut, you have to break a rib, you have to spread the rib here on the right, and then with a minimally invasive operation, just some small ports, and so there's definitely less pain, it's faster, people have faster recovery, fewer complications, and it's safer for older patients. In terms of what happens after surgery, your folks will have a plastic tube coming out of the chest, it's called a chest tube, and that will drain any fluid and air that's leaking. And usually patients are in the hospital 1 to 3 nights, and recovery it can range from 2 to 4 weeks, and sometimes people need a little bit longer as well. And then you want to make sure to go over the reports from what the operation showed, and that's called a pathology report, and making sure that the margins are clear such that there's no lung cancer left in the body, that lymph nodes were taken, and that if it's stage 1A, then there's no further.
I think we may have lost Dr. Yang. Jeff, can you still hear me? Okay. Let's give him a minute or so, and if he can't join in the time, maybe we can start with some panel questions. Okay, well, I think he's trying to rejoin, and perhaps we can start with some panel questions with Dr. Das while we're waiting for Dr. Yang to rejoin. And Dr. Das, are you available to join?
Yep, I am.
Perfect. Okay. Hey, Jeff, I think we lost you a little bit, but
Okay,
it was
sorry about that. I think I was finishing up. I was finishing up anyways. It's basically just mentioning that for more advanced stage disease, surgery is still possible for certain situations, but you would have to consider giving other types of medicine before surgery or medicines after surgery, such as chemotherapy and immunotherapy. So I think that's
perfect. So those were excellent talks, just really summarizing kind of the breadth of data out there and what we think about when we think about early stage lung cancer. And so for me, I just wanted to start perhaps in determining, because I know that everyone has different backgrounds, different levels of expertise, kind of defining some of the terms that we talked about. And so one term that came up quite a bit was kind of neoadjuvant, perioperative, adjuvant. And so how do we think about those things? How do we define those terms? And then what is the difference? Like in your clinical practice, is there an advantage to one approach versus another for a patient or even biologically? And perhaps we can start with Dr. Das for that one.
Yeah, I think it is confusing. So we think about sort of neoadjuvant treatment being treatment that's given before surgery. We think about adjuvant treatment being treatment that's given after surgery. And we think about perioperative treatment really being both of those things. So patients being referred for treatment both before and after surgery. And I think that's, so just the terminology there, I think is important. And I think really kind of one of the big questions as we think about all the trials that we have neoadjuvant trials, we have perioperative trials, and we have adjuvant trials. And so I think we need to really think about which patients should be getting neoadjuvant alone, which patients should be getting adjuvant alone, and which patients should really be getting a perioperative, both the neoadjuvant and adjuvant treatment course.
I think very well said. And so another thing that we talked about was stage. And just Dr. Yang, just very kind of in the broadest level, what constitutes a stage 1 versus a stage 2 versus a stage 3? And are there some stages where you might not actually need any of this adjuvant, neoadjuvant, or perioperative systemic therapy, where surgery perhaps may be enough?
That's a great question. So for stage, it's a general way of describing how much lung cancer is in the body. And so for earliest stage, we think about a tumor that is under 3 centimeters and something that's in the lung but under 3 centimeters and has not spread to anywhere else in the body. So it hasn't been in the lymph nodes, it hasn't been in other organs. And if that's the case, then all you need is surgery, and you do not need any other types of medicine that we have been talking about, like chemotherapy or immunotherapy. In terms of once tumors are bigger than that, then there's been a lot of discussion about using surgery as one part of treatment together with other kinds of medicine. And so that's really exciting in our field. It's rapidly evolving. And so for stage 2 and stage 3, there has been a lot more talk about using chemotherapy, immunotherapy in combination with surgery, and certainly with looking at specific biomarkers and seeing if patients have, for example, EGFR mutation positive lung cancer. Are you going to take some medicine after surgery? Or even before surgery. And these are things that are still moving parts, but people are really strongly considering and have helped patients live better lives.
Exactly. And I think you touched upon one aspect of all of this at the beginning, is that the highest chance of curing or kind of getting rid of the cancer forever is when we detect it at the earliest stages. And so very, very important, a big plug for lung cancer screening as well. And also a big plug for thinking about how we think about who should be eligible for lung cancer screening. So some of the things that you touched upon, kind of EGFR mutations, et cetera, may not necessarily be present in the population of patients that we currently think about as eligible for traditional lung cancer screening. And so that's how the field is evolving. And so you mentioned the word biomarker. I think it's a very important topic and a very important point. And so Dr. Das, you'd mentioned kind of immunotherapy, but Dr. Yang has just also referenced a targeted therapy, so EGFR targeted therapy. And so if a patient qualifies, kind of has early stage lung cancer, perhaps they qualify for immunotherapy, chemotherapy, EGFR targeted therapy, how do we think about prioritizing those types of therapies for a given individual?
Yeah, it's a great question. I think as I showed you, these perioperative trials, patients who had the driver EGFR or ALK were excluded. So, so for these, we really do think about these patients a little bit differently. And these are patients with EGFR or ALK are really felt to derive less benefit from immunotherapy. In fact, at our tumor board earlier this week, we had two stage 3A patients, one who had an EGFR mutation and one who did not. And when we were thinking about the treatment approaches, we ended up deciding on a perioperative treatment approach for both of those patients. But for the EGFR patient, we did not think about adding immunotherapy. Again, these patients were excluded from the perioperative immunotherapy trial. So this was a patient that we recommended neoadjuvant chemotherapy for, no immunotherapy. And then afterwards, after surgery, the recommendation was for that patient to get adjuvant osimertinib as per the DORA trial. So I do think we are in this era of trying to individualize treatment based upon driver mutation status, based upon PD-L1 expression. Again, as I showed you, the patients who have some degree of PD-L1 expression seem to have greater benefit with the immunotherapy. Does it mean that a patient who has no PD-L1 expression should not be offered immunotherapy? Not necessarily. And I think these are the nuances that we're trying to figure out. And then what do we do for patients with other driver mutations outside of EGFR and ALK? And again, we don't have definitive answers for this. I think a lot of us, who treat these patients with other driver mutations in the setting of being never smokers or light former smokers, again, that benefit of immunotherapy is I think really called into question. And so these patients still may be offered just neoadjuvant or perioperative treatment without immunotherapy. But, I think that there's a lot of discussion about this, and I think we're still trying to sort these things out.
Yeah, very, very well said. And I guess one thing that comes up in what you were discussing is that we used to think about biomarker testing as something we did for advanced stage mostly, right? Something that wasn't particularly relevant for early stage. And now as we're getting these therapies that really are nuanced, to borrow the word that you use, right? It depends on what your tumor markers are. It's becoming increasingly important for us to test. And perhaps I would even kind of venture to say test broadly upfront instead of just looking at EGFR or ALK. And so that's something that for patients, that's something your doctors are thinking about too, right? And I know sometimes it can be unsettling when you have a new diagnosis of lung cancer and someone says, hey, you have to wait a little bit because we have to get all the information before we can formulate the plan. And so one question from the chat. Oh, it looks like it has been answered, perhaps.
I answered it, yeah.
Perfect. Perfect. And I guess one question that often comes up is that getting back to that kind of anxiety with a new diagnosis of lung cancer, right? The idea that instead of cutting it out, we're going to do all this therapy up front and then we're going to wait to cut it out. Do we have any idea of kind of what is the toxicity of kind of perioperative or preoperative therapy? What proportion of patients from our trials don't make it to surgery? And then for Dr. Yang too, I have patients who are kind of afraid of surgery, right? It seems like a lot, even though there's a robot now, as you said, like cutting edge, there's smaller incisions, but what proportion of patients actually don't survive surgery? I think it's important to hear those types of numbers too. And so maybe
definitely, maybe I'll go first because it was the most recent question. But absolutely, I think that it's really important to know that surgery does have risks. In terms of every once in a while, unfortunately, folks do not make it after surgery. However, the good news is that in 2024, that number is really, really, really low. So I would say that nationally now, that number is less than 1%. So less than 1% that patient doesn't survive after surgery for early stage lung cancer. And in fact, in some studies, it's 0%. It's remarkable. And so I think that things to pay attention to when you go, if you have to talk to a surgeon, is to see how much experience that surgeon has had, and also if you can get a sense of what types of operations they do, because minimally invasive surgery is by far the best. But there are some places across the country where surgeons haven't had that much experience and they still do open surgery. They still do the big incisions and for early stage lung cancer. And so I would probably ask those types of questions to figure out where is the best place to get your operation.
I think on a similar note of what Dr. Yang is, we saw a patient this week, again, with that stage A disease, where the patient had met with a cardiothoracic surgeon in a community setting, and that surgeon did not feel that patient was resectable. So how do we define resectability? And is this really in the eye of the beholder? And I think it's getting more and more complicated. And so, I do think it's great when patients seek second opinions from dedicated thoracic surgeons, because as you can see in the eligibility criteria, how is resectability being defined across the trials? We also saw that about 20% of patients across the trials did not go on to get surgery for whatever reason. And so I think really, selecting the appropriate patient for surgery, the goal of this perioperative treatment or neoadjuvant treatment is not to make unresectable tumors resectable. It's really to define upfront who are considered to have resectable disease. And as you can imagine, over the years, that resectability has changed, that definition of resectability. And I think it really also depends on who you see as a surgeon. And so I don't know, Dr. Yang, your thoughts on the sort of the differences in defining resectability.
Yes, I do think that, to your point, so I trained at Stanford, so I absolutely love the Stanford thoracic surgeons. And it does, for more advanced stage, I think it's really important to try to so if you have advanced stage or more advanced stage lung cancer, I think it's really important for you to go to a place that has thoracic surgeons that work closely with medical oncologists and radiation oncologists together as a team, to define what can actually be resected and what can be taken out. Because in this era of all these exciting medicines, previous tumors that previously would have been thought to not be able to be taken out could possibly be taken out. On the other end of that consideration is you also don't want to go to to a surgeon who says they're going to take out something that really ought to not be taken out. And so that's why it's so important to have this, what we call a multidisciplinary discussion, where it's a team effort, where you talk to everybody and get all their opinions together. So in terms of my patients, going back to Dr. Degogojac's question of how well they have been able to handle the side effects of chemotherapy and immunotherapy, I've been pleasantly surprised, actually. I wasn't sure how tough of a regimen it would be, and for most of my patients, they actually were able to get chemotherapy and immunotherapy and get surgery and do well afterwards. So I'm grateful that they've had that experience. Obviously, there are some patients who don't do nearly as well, but I would say most of my patients actually have done really well through that regimen. So.
Yeah, and that's been my experience as well. And I think on a biological level, there are reasons to try to give that therapy up front too, and also practical, right? Practically, it's easier to give the therapy before surgery. There's a recovery after surgery, and it's harder once you kind of climb that hill to then kind of contemplate months of kind of additional therapy and even years when you add the immunotherapy to it. And at the same time, at a biological level, we tend to think that the immune system is better educated when you have the bulk of the tumor intact, the lymph nodes are there, everything. And so it can be better educated to patrol or traffic the body and seek out the tumor, a little, what we call micrometastases afterwards. Dr. Yang, I noticed that you did not use in your talk, there was no mention of a pneumonectomy. So I just wanted to discuss with you, has that fallen out of favor where people kind of remove the entire lung, right? I thought about it when we were talking about how much is too much.
Yes, so I think I focused my talk more on early stage lung cancer, but you're absolutely right. Another type of operation which I missed, well, I should say maybe two. One is called a sleeve lobectomy. This is a more extended operation where you still take out a lobe, but then you have to do some airway work. And then the other one is a pneumonectomy where you take out the entire lung. We still consider taking out the entire lung in certain situations, but it is much tougher to experience that than taking out a smaller piece of lung. And so it's, in general, if we can avoid a pneumonectomy, we absolutely try to. That said, we have had patients, especially who are younger, who have maybe who have had more advanced disease, but really need, in order to completely take out the lung cancer, you'd have to take out the entire lung, who have done very well. And I've been pleasantly surprised. I do a lot of, as you mentioned, Dr. Degogojak, I do a lot of lung cancer awareness and screening awareness. And I met a mayor in Haverhill, Massachusetts, who, and this is public knowledge now, so I'm not giving away anything, but he underwent a pneumonectomy. And he's in his 70s and he's doing really well, and he's actively just being very active in his city, and so you can definitely still do very well after even that big of an operation.
Yeah, I think it just really goes to speak that everything is individualized, right? It's really what is best for the tumor, and the ultimate goal is like, how can we get rid of this? How can we prevent it from both recurring locally and also systemically? And so one question in the chat, Dr. Das, I think that we were all kind of floored and kind of inspired by the number of trials that you were mentioning in this space. And so someone has asked a very practical question. Do we think that we'll be using all of these regimens, or do you think that we're going to winnow it down to a couple at the end of the day, or a couple of these kind of chemotherapy regimens? Do you think, I mean, I don't want to put you on the record, do you think that there's going to be a prioritization perhaps of perioperative versus adjuvant therapies as well?
I mean, I think that I don't think we really know. I think with these, regardless of the immunotherapy agent, I mean, we have data for nivolumab, pembrolizumab, durvalumab, atezolizumab. I mean, again, in the metastatic setting, we sort of interchange them as well. So I think I don't think that one particular trial wins out. And again, I think we do have to think, as Dr. Yang mentioned, I mean, absolutely have that multidisciplinary discussion from the get-go. And now even for patients potentially with stage 1B disease, these are not necessarily patients that we would be discussing at a tumor board. But as you saw, a lot of the trials, did include this patient population, but certainly stage 2 and 3 patients absolutely need to be reviewed. And we need to really come up with the best treatment strategy when it comes to which immunotherapy drug to use. I don't have a favorite. I don't recommend any one over the other. And I think a lot of us are just, using these different drugs. I mean, in the perioperative space, there's, a certain number of drugs that have been used and approved in the neoadjuvant and then the adjuvant. I shared that data with you. And so, I think we're all trying to kind of figure out, who needs that neoadjuvant alone, who needs the perioperative, who needs the adjuvant, because we have different drugs that are approved in those different spaces. And I think one of the other questions here was, should patients with more extensive disease who might have not been felt to be strong candidates for surgery historically now be offered perioperative treatment? Again, it speaks to this question or need disciplinary discussion and then talking to a surgeon who is familiar with doing lung cancer surgery and really trying to figure out, is this a patient who's an appropriate candidate for surgery up front? I think, we need to make those decisions, kind of at the get-go for patients who are not really considered to be surgical candidates. And again, this goes back to this resectability question. These are patients that may be better served with definitive treatment with a combination of chemotherapy and radiation therapy. So there's alternatives too that we need to consider.
Exactly. And that's even without saying that even for people with the earliest stage of lung cancer, sometimes surgery is not an option. Dr. Yang had on his first slide considerations. In those cases, I would not despair. We have radiation. We have Dr. Iyengar here to talk about it in the stage 4 setting, but we often, most often practice it in the earlier stage setting, and then all sorts of techniques such as ablation and other things. And so with that, thank you so much, Dr. Das and Dr. Yang. We're going to wrap up the first segment of today's program, and we're going to turn towards the second segment. And to kick us off, I'm going to introduce Dr. Luda Bajanova. Dr. Bajanova is a thoracic medical oncologist. She has extensive expertise across early stage, late stage, mesothelioma, all sorts of subjects. So it's really a pleasure to have her today. And we have tasked her with talking to us about kind of emerging therapies for lung cancer, not necessarily chemo, immunotherapy, et cetera, but she's going to talk to us about what we call antibody drug conjugates as well as bispecific therapies. And so I will turn it over to Dr. Bajanova.
Hold on one second. Can you guys hear me?
We can, yes.
Okay, perfect. So hold on. I just did something that I shouldn't have. Okay. So morning, everybody. For those of you who it is afternoon, good afternoon. I am Dr. Luda Bajanova. As it was mentioned, I'm a thoracic medical oncologist practicing in San Diego, California at the University of California, San Diego. And my task today is to discuss two novel classes of systemic therapy, which is antibody drug conjugates as well as bispecific antibodies. So we first start with antibody drug conjugates. In order for us to understand what the antibody drug conjugate is, we first need to know what the antibody is. But before we go there, I'd like to discuss a little bit about chemotherapy. So chemotherapy is effective in patients with lung cancer, but sometimes it feels like a picture on a right. In addition to killing cancer cells, it does have an ability to kill healthy cells, at least initially. The mechanism why chemotherapy in lung cancer works, or in any kind of cancer for that matter, is the traditional healthy cell will recover faster than the cancer cells. And so you have an increased differential killing effect between healthy cells and cancer cells. And the reason why there are we call the broad toxicity with chemotherapy is because it has harder time differentiating between healthy cell and a cancer cell. And therefore, we always been looking for better chemotherapy options, or now we are entering what we call a smarter approach to chemotherapy delivery. And that leads me to the to the antibodies. So what are antibodies? So antibodies are a special Y-shaped protein, and you can see on the top right of my slide, an example of a Y-shaped protein, which is an antibody. Antibody are produced by our immune system. There are certain cells in our immune system called plasma cells, and sometimes B cells that are able to make antibody. Antibody is made by design. So when your body makes an antibody, it makes it for a reason. It makes it to attach to something that's called antigen. So antigen is also a protein or can be a sugar molecule, and that is generally present on the surface of any cell, healthy cell, cancer cell, virus, bacteria. And the antibodies are specifically made to attach a certain antigen. For example, if you see at the tops of my slides, you see that there are different antigen, different color, different shapes. And so this antibody will only fit or will only attach to a green antigen, will not attach to yellow or purple or blue because it is not designed to do so. And then, for example, at the bottom right corner, you see a cancer cell, and you can see on the surface of the cancer cell, there are different antigens, so like red, green, and blue, and they're like square and semi-oval and triangle. And so this antibody is designed that it's only going to attach to a triangle. It's not going to attach to the square or the semicircle. So you kind of think about antibodies is like a puzzle pieces, right? So in order for the piece to fit, the puzzles have to be created so the opposite side fits perfectly well. The challenge with antibodies is that it is a big molecule. So compared to chemotherapy, chemotherapy can go inside the cancer cells. Earlier, we were talking about EGFR targeted therapy. So EGFR targeted therapies, we call the small molecule inhibitors, and they are also able to go to the cancer cells inside. The antibody cannot do that. It has to attach to the surface. So the question is, if the antibody does not go inside the cancer cell, how does it kill cancer cells? Why? By attaching itself to the top of the cancer cells die. And there are several ways of doing it. So one of them is you look at, it attaches to the surface of the cancer cells and kind of blocks the signal through the receptor. So the way you think about it is like if you have an electric car and, electric mechanics, things is scrambled for one or another reason, your car cannot drive because all the electricity has been scrambled. The second way it does so, once it attaches to the cancer cell, it kind of marks the cancer cell for degradation by immune cells. So kind of you think about it like I'm attaching a post-it notes to the cancer cell saying this cell needs to die. And then an immune system will go in and kill that cancer cell. And the third ability of monoclonal antibodies in general killing cells is where what the antibody drug conjugates are specifically hijacking is an ability of the cell to take the antibody inside. So once the antibody is attached to the cell will kind of engulf the antibody and put it in the middle. And that's shown on the right side of the slide with a yellow cell. And you see the antibodies, you see that Y-shaped protein is going to be moved inside the cancer cells. So antibodies are great, but amount of antibody your body produce is small, and it's very difficult for us to extract that antibody from the human in sufficient enough quantities to kill cancer cells. And also your body has an ability to limit those antibody production, and that's called protection or self-immunity. So the body will not make too many antibodies. And so that's where the science helps. And then we use something that's called the monoclonal antibodies. So you can make a lot of those antibodies in the laboratory. And the reason why they're called monoclonal, because they are clones of one protein. So they are identical. And the way it's done in the lab, you take a mice and you inject the mice with an antigen. The mice will make an antibody. That's what every kind of being on the live being on the surface of the earth does, it makes the antibody. So then you sacrifice the mice, and then you take the spleen cells, that's where those cells that makes the antibody live, and then you take a myeloma cells, like a certain kind of myeloma cells, and you put them in the same petri dish, and those two cells will fuse, so they became a hybrid, and that's called a hybridoma model. And that hybrid is now able to make a lot of antibodies in a petri dish. And those antibodies, again, as a puzzle, they specifically design to attach to the certain antigen that you injected in the mouse in the first place. And so that leads us to, now we understand what antibodies are, now we understand what monoclonal antibodies are, and now what are antibody drug conjugates. So antibody drug conjugates is a molecule that has three components. So number one is the monoclonal antibody that we just learned about. It's Y-shaped protein that's specifically designed to attach to a certain portion of the cancer cell. We are very smart that when we decide what antigen to use, because we want to use the antigen that's only present on a cancer cell, but not present as much in a healthy cell, because if it would be present on a healthy cell, it will kill the healthy cells at all as well. And so that kind of defeats the purpose of specificity of our treatment. Then we have something that's called a linker. So linker attaches the chemotherapy. So here in this picture, you see the skeleton symbol, that's the chemotherapy molecule. And then we specifically choose chemotherapy that we know can kill cancer cells. And then you attach that chemotherapy to the linker. And linker is very important because you want to choose the linker that will not disintegrate once you injected the antibody in the patient's vein, because if it disintegrates right away, then it's not going to get to the cancer cells. It's going to, disintegrate in the blood, and you're just going to have chemotherapy molecules just floating around the blood, which is the same as we do with traditional chemotherapy. So you select the linker that will only release the chemotherapy under certain environmental conditions, which are generally pH, because the pH or concentration of hydrogen ion is different inside the cell than outside of the cell. And you also select it sometimes based on the certain concentration of sodium and potassium. And so the purpose of the antibody drug conjugates is to seek out cancer cell and deliver chemotherapy directly into the cancer cells, and therefore that potentially limits the side effects of chemotherapy. So the way I think about antibody drug conjugates is kind of a Trojan horse, because when cancer cell takes the antibody drug conjugate, it has no idea that there's a chemotherapy attached to it. So we're kind of fooling the cancer cell by allowing them to think that this is something benign, and they will take that molecule. So what happens when cancer cells takes the molecule, so it's kind of a cartoon. So you have a cancer cell, a tumor cell, and then you have a antibody drug conjugates, again, Y-shaped protein, and then you have a linker, and then like this antibody has 4 chemotherapy. We call them warheads. I don't know why, but we do. So 4 chemotherapy molecules attached to a single antibody. So that antibody will attach to the cancer cell. So the third picture of this kind of semi-lunar picture, where the cell will actually engulf the antibody, will take it inside. Inside the cell, it will fuse with a structure called lysosome. And lysosome, what is responsible for cleaving or kind of cutting the linker and allowing chemotherapy to be freely diffusing inside the cancer cell, and that causing cancer cell to die. Antibody drug conjugates do have toxicities, and some of them are chemotherapy-like toxicities like nausea, vomiting, alopecia, but some of them have a unique toxicity such as keratitis, which is inflammation of the front part of your eye, pneumonitis, which is inflammation of the lung, and then mucositis, which is an ulcers of the mouth. So you might ask me, I was just touting the antibody drug conjugates and saying it's so specific. It's just, it's better than chemotherapy. It's a Trojan horse. It's more of a targeted delivery of chemotherapy. But I'm showing you that this targeted delivery still have side effects. And the question is why the antibody drug conjugates still cause side effects. And we think that there are several reasons for that. Number one, even though we are trying very hard on selecting the antigen in a way that it's not expressed or not present on a healthy cell, it is never going to be 100% guarantee. So that target protein will be present in a healthy cell. So you can see in the middle part of the graph, it says distant normal cell. So that's a normal cell and the target is being expressed. And so the antibody drug conjugate will also attach to some portion of a normal cell. And then another thing, remember on a previous slide when I showed you where the chemotherapy molecules kind of free in a cancer cell, once they are in a cancer cell, they can actually diffuse out of the cancer cell and then interact with the nearby healthy cells, and that causing side effects. And also the third reason why we think antibody drug conjugates still have side effects is because of the linker. Even though our linker is designed to only release inside the cancer cell, nothing is truly foolproof in medicine. And there are sometimes you can have some release of the chemotherapy in the circulation before it reaches the cancer cell. So what antibody drug conjugates we have in lung cancer? Currently, there is only one antibody drug conjugate which is approved. This is for patients with stage 4 lung cancer and a mutation in a gene called HER2, HER2 exon 20 insertions. There are other antibodies in development. I think the ones that, in my opinion, is a little bit further along and have a really good efficacy data, does not yet have an FDA approval, is patritumab deruxtecan. It's an antibody against HER3, and it's currently being developed in EGFR mutated secondary resistant non-small cell lung cancer. We have an antibody against TROP2. There are 2 companies having an antibody against TROP2, and they are being developed in newly diagnosed stage 4, treatment naive, as well as previously treated. Then we have a MET antibody drug conjugate. It has a complicated name, but we call it Teliso-V, and it's currently being developed in patients with EGFR mutations who develop secondary resistance through the pathway called MET. And then there is a CCOM monoclonal antibody. We don't know yet where that is going to fall because there are some negative studies, so I'm not sure the company where they're going to develop that antibody further. That's why I put a question mark. So this is the only antibody drug conjugate that's currently approved. This is what we call the waterfall plot. I'm the first one showing the waterfall plot, so I'll explain you what that is. The reason why it's called a waterfall plot, because it looks like a waterfall. Every single bar represents a patient. So at time 0, we all start at time 0. And as your cancer shrinks with treatment, that is the bar goes down. And the height of the bar depending on what's the percentage of cancer shrinking. And then we just kind of rank them in the order. So you can see on the very right side of that waterfall plot, there is a patient who had 100% decrease of the tumor, meaning all the cancer cell went away on the imaging. And then on the left side of the slide, you see the patient where the bar is going above 0, going up. That means that the patient cancer unfortunately grew on this therapy. So overall, there is almost 55% of the patients who responded on this therapy. The median time before the treatment stopped working was 8.2 months, and the median survival on this clinical trial was almost 18 months. And so that kind of finishes my talk about antibody drug conjugates. And now I'm going to discuss bispecific antibodies. So it's again the same antibodies, the same Y-shaped protein, the same monoclonality, so produced in a lab in the mice. But now there is a word two. So bi means two. So we have a word like bilingual, meaning knowing 2 languages. Bicycle, meaning having 2 wheels. So bispecific antibody means that there's 2 parts with that antibody. So going back to our, structure of the Y-shaped protein structure of antibody. So you can see that Y-shaped structure has 2 ends, one on the left, that's I circled in the red, one on the right. And you can see that those ends are identical. So when they're gonna bind the same green antigen that I showed you in the beginning. So that means that this antibody is monospecific, meaning it only can attach one thing. But you can actually design an antibody where 2 different parts of that Y structure, one part is going to attach to one thing, another part is going to attach to another thing. So that's shown on the right side of the slide. So it fits 2 different puzzle pieces. And that's why left is in green, right is in brown. And then you can pretty much take the traditional antibody, that Y-shaped protein that have an identical ends, and then you can do mix and match. And you can design all kind of stuff. As you can see here on the right side of the slide, you can have, there is a green parts and a yellow and the blue parts. You can actually do what's called a tetra body, where you actually have 4 connections. And so we do it all in the lab. And the idea is that that bispecific antibody is going to bring 2 different things together. So what 2 different things can bispecific antibody bring or bridge? So they can bridge cells. They can take an immune cell and just forcefully force the immune cell to go next to the cancer cell. So it kills the cancer cells rather than them just floating around. You can bridge, can take 2 tumor cells and bridge them together. And by doing that, you scramble the signal of that tumor cell. You can bridge receptors. You can take a tumor cell and then take, let's say, a receptor again on the immune cell and some other cell and just bring them together. Or you can bring the cytokines. So cytokines are the structures or the molecules that has an ability to kill things. And so you can also bridge the cytokine. So this is kind of a cartoon example. So you have a bispecific antibody, again, that Y-shaped protein that I've been talking about, that airplane. And it basically, what it does, it takes a part of the, like here on the left side, it's an immune cell, the T cell, NK cells, and it basically forcefully attaches to the cancer cell. And then on the very right part of the slide, it's showing you how they can attach different cytokines and also help that to kill cancer cells. So we have a lot of bispecifics antibody in development. The only one drug we have currently approved is called amivantamab. I'll show you the data for that in a second. But we have different antibodies in development. And so second column is you see what 2 things is the bispecific brings together. For example, zenocutuzumab is going to bring HER2 receptor, and HER3 receptor is currently being developed in a very rare molecular disease, which is called NRG fusion. Then you have ivonescimab, which is currently being developed in lung cancer for patients who have mutations and don't have mutation. That brings PD-L1, which is an immune receptor, as well as VEGF, which is a blood vessel receptor. And then the one that we are very excited about is tarlatamab, which is developing for small cell, and it basically brings the immune cells. That's why CD3, it's a receptor on the immune cells, and DLL3, it's a receptor on the cancer cell. So it basically forces the immune cell to attach to the cancer cell. And then we have other ones, which is combining 2 immune molecules, like PD-L1, as I already mentioned, it's an immune molecule, as well as TIGIT, which is another immune molecule. And then you have a PD-L1 and CTLA-2 in the last example. But again, the only drug we have approved in lung cancer is amivantamab. And so this is the data behind amivantamab. So what is amivantamab? It's a bispecific antibody. I showed the cartoon on the right side of the slide. One part of the antibody attaches to MET, which is a receptor in a cancer cell, and another antibody attaches to the EGFR, which is also a receptor on a cancer cell. Currently, amivantamab is only approved for patients with a very rare mutation in lung cancer called EGFR, exon 20 insertion, and this is the results of the study. It showed 40% of the patients responded about 8.3 months before the cancer progressed, and the median overall survival on that study was 22.8 months. So in summary, we are very excited. We are looking forward to have approvals of 2 new classes of drugs in lung cancer, and those are called antibody drug conjugates and bispecific antibodies. Currently, we only have 2 drugs which are FDA approved, which I mentioned, trastuzumab deruxtecan, which is antibody drug conjugate for a rare molecular subtype, which is a HER2 exon 20 insertion, and amivantamab, also for a rare molecular subtype, which is EGFR exon 20 insertions. And of course, I'm always hoping to have more medications approved in that space. Thank you so much.
Thank you so much, Dr. Bashanova. That was very, very informative, and I'm looking forward to the panel session later to just kind of dive deeper into some of these. So our final speaker is Dr. Puneet Iyengar. He is a radiation oncologist. He is at Memorial Sloan Kettering. He's a basic scientist who does research in thinking about how can we best integrate systemic, so all the therapies you've heard about from Dr. Bajanova and Dr. Das, as well as local therapy, so a different type of local therapy here, radiation therapy, as opposed to surgery that we heard from Dr. Yang. So with that, I'll turn it over to Dr. Iyengar.
Thank you very much for this opportunity to talk today. And I'm always extremely grateful to be able to present work in front of Grace and its larger community. So this is a long title, and I can really summarize this in about 5 or 6 words, which was the original title, which is how can we use radiation to improve outcomes and quality of life in patients with metastatic lung cancer. These are my disclosures. And so at the end of the day, I would make the argument that our medical oncology colleagues and our preclinical colleagues have done an amazing job at increasing the portfolio of medications and drugs that really make a powerful survival impact on our advanced lung cancer patients. As you can see, this study, that was really one of the early integrators of immunotherapy and chemotherapy versus a placebo and chemotherapy. And so, you know, the real idea was that there was really benefits, but, you know, always trying to do better and trying to do better for our patients. We realized that over time, these curves reduced in terms of overall survival percentages. And so what we need to do as a group and what we need to continue to do is to better understand how to make these drugs work more durably. And I think part of the explanation of why we're still not optimizing our approaches is, in general, lack of predictive and prognostic biomarkers. And this is a little bit of a dated slide, but I still show it because it still suggests that, you know, a majority of our solid tumor cancer patients, including non-small cell lung cancer patients, don't have a very durable response to frontline immunotherapy. And so it begs the question of, you know, what more can we do to optimize these outcomes for our patients? And as Dr. Bazanova was just pointing out and looking at our waterfall plots, you always notice that the waterfall plots go from shortest response to longest response. But each one of those represents potentially a patient. And what that means to me is that there's an extreme variability in how effective a systemic therapy is. And this slide presents the same exact information. As you can see in the red box, this is a progression-free survival on first-line EGFR inhibitor osimertinib. And you see that 4 patients have the exact same exon 19 mutation, yet you see a vastly different response to the first-line therapy, with some of the patients having progressive disease, whereas others have disease that extends, progression-free survival that extends beyond 50 months. And so that variability would point to both tumor intrinsic biology, maybe co-occurring mutations, maybe other biology that we haven't really thought about or are in the process of thinking about. It also talks about the potential for our host biology, meaning, you know, how our immune systems respond to a tumor, how our immune systems respond to a therapy that really dictates how we optimize outcomes. And so what you've heard earlier from even earlier today is the idea that now every stage of non-small cell lung cancer is really a ripe opportunity to treat all stages of cancer with every single treatment modality, whether it's systemic therapy, by pill or infusion form, by surgery, and by radiation. So as a field, we need to better understand how to integrate all of these different modalities in whether it's a sequencing question, whether it's omitting one or adding a therapy to optimize how we do best for our patients. And so the idea of using local therapy in the form of radiation and surgery for metastatic patients is actually, people think it's a relatively new one, but I'll show you that there was efforts to do this way back in the day. But why has it become more important and more relevant in the last few decades? It's basically what I just described. With modern systemic therapies, its utilization and availability are more obvious. These systemic therapies are doing better and better, but are still not perfect and cannot stand alone. And with modern diagnostic tools that allow for the detection of early metastatic disease, can we add local treatments in some settings of advanced disease to optimize our therapeutic outcomes in either making our patient's disease curable or at least chronic, in which case they live for a long period of time, but we have to keep coming back and treating every so often. Other evidence that supports local therapy was the fact, local therapy beyond palliation. Local therapy in the form of radiation has been used in palliation for many, many, many years. But to use it to try to improve survival outcomes is what we're really talking about today. And one of the important points to notice is that when patients have stage 4 lung cancer and they have first progression, usually the first sites of progression are in the original sites of gross disease, which would indicate to us that if we could somehow use a local therapy at these original sites of gross disease to facilitate the systemic therapy in controlling progression, then these patients may have a much improved progression-free survival interval. We can also take experiences from our surgical colleagues who have historically, for metastatic diseases like sarcoma and for colorectal cancer, have removed lesions that have spread to the liver, for instance, that have spread to the lungs, for instance, and even the brain to optimize a survival outcome and not just a progression-free survival outcome for different patients. So this all comes back to now this idea of oligometastatic disease, oligo meaning few, metastatic sites of disease. And Wexelbaum and Hellman really made the concept popular in the mid-1990s. But as far back as the 1930s, surgeons were trying to resect lesions that they could see, metastatic lesions, in the hopes that removing these metastatic lesions could improve the survival of their patients. But what has made it important for us to start really thinking about local therapy in what we call this oligometastatic state, which is a state between earlier stages of disease and then first sites of metastatic disease versus a patient who's developed metastatic disease throughout their body and more globally. And it's really the 2 points that I brought up earlier. One is systemic therapy has gotten better, which means that there's a higher potential likelihood that we find patients in an oligometastatic disease state. And number 2, with improved imaging, that also has allowed us to catch metastatic disease at an earlier stage in development. And the third point I would try to make is there was an evolution in our radiation approaches, and one of them was called SBRT, stereotactic body radiation therapy, and it allows us to use high doses of radiation to deliver treatment to very small volumes of disease or relatively small volumes of disease in any part of the body. And it's done in very few treatments, and that's the trick. It can be done in very few treatments. It can lead to killing of cancer and synergize with the systemic therapy, and it's done with limited toxicity. And so it was the evolution of that technology along with the imaging and better systemic therapy that has led to more and more studies that are trying to impress upon us the need to use local therapy in the advanced setting. So I'll focus primarily on 2 distinct time points where we think radiation therapy can be valuable. One is called consolidation, and that's timing after which patients with stage 4 disease have received their initial systemic therapy. It could be 3 or 4 courses. It could be up to 6 courses. They've had a good response to therapy, either stable disease or good positive response to therapy. They have limited sites of disease. And our question is, if we add radiation in those conditions at that point in time, will we allow our patients to live longer? And so, this is a complicated table. I'm just going to point some very important, highlight some very important points. Number 1, multiple randomized studies, as highlighted in the red arrows, suggested that doing this approach, taking half the patients and letting them just receive systemic therapy and letting the other half get radiation at this time of consolidation followed by continuation of systemic therapy, the patients that received the radiation to their limited metastatic sites ended up having very significant improvement in progression-free survival, or the time before which they progressed. And they also had, in 2 of the studies, an improvement in overall survival. So why did this potentially work? Because the use of radiation changed our failure pattern. No longer were these patients failing within the areas that they originally had disease because we were radiating them. They were now failing in distant sites, and they were doing so at a later point in time. So this was certainly a very exciting set of studies. One caveat is that none of these studies were in the modern era of utilizing immunotherapy. So that's what led to a larger study in the modern era of immunotherapy that was initiated back, I think, in about 2018, NRG LU002. It was a large group of wonderful collaborators on this study, and it asked a very simple question. You have stage 4 patient at diagnosis. After you've received this first-line systemic therapy for about 4 courses, do you have oligometastatic disease? Meaning, do you have 3 or fewer sites of metastatic disease? And if so, we will randomize you to receive radiation, followed by additional systemic therapy in the form of immunotherapy or chemo, or the other half of patients, or in this case, third of patients, will receive just systemic therapy and no local therapy. So we finished randomizing 218 patients from 68 sites as part of a phase 2 portion of the study, and then did some interim analyses. At this point, it is the largest study ever looking at the role of radiation in metastatic lung cancer patients with stage 4 disease. So it really became a study that was asking the question of patients with immunotherapy, receiving immunotherapy, minus plus local, what we call LCT, local consolidative therapy. Did the patients with LCT or radiation do better? And so I wanted to highlight, just because it's not often that we do, some of the statistics and facts that we collect in one of these studies. In this case, the median age of patients was about 65. There was an equal percentage of males and females on this study. About 77% of patients were white males. Histology-wise, it's the standard distribution that we would see. About 75 to 80% of patients had non-squamous histologies, and the other had squamous. Again, I mentioned that about 90% of patients received immunotherapy. And when we looked at the number of patients with metastatic disease, or the number of metastatic sites, and remember, the eligibility requirement was 3 or fewer extracranial metastatic sites. Most patients had 1 or 2 metastatic lesions, not widespread disease. And this is the subset of patients that we wanted to show a benefit on. And we looked at, and then we did the interim analysis, and we looked at many different patient characteristics, including adverse events. And there was a slight increase in adverse events with respect to pneumonitis in the patients that received the radiation in addition to the systemic therapy. We have also done quality of life studies, which is very important in this patient population, but we haven't read those out yet. Unfortunately, the interim analysis was supposed to let us know whether we were going to go on to randomize 400 patients. But unfortunately, the benefit that was seen with LU002 with the use of radiation was limited and wasn't enough for us to proceed to the phase 3 portion of the study. And one could, make an argument, why did we not see the same breakthrough improvements in PFS and OS that we saw in the earlier, smaller randomized studies? And one aspect is that perhaps the immunotherapy in the era of immunotherapy did much better than chemotherapy, which we would expect, but so much better that it diluted the benefits that radiation would offer in this patient population. The other, and then these are still facts that we're still looking into, the toxicity, though there was a move towards an improvement with radiation therapy, the toxicity kind of diluted the benefits that the radiation was offering. So we are looking at this study, looking at other studies to try to see if we can identify a benefit. And then the last thing I would say in this consolidative phase, I would say is upfront, is that patients with EGFR inhibitors, there are multiple studies that have now looked at use of radiation upfront in this case, and they showed an overall survival benefit. So, we're still trying to figure out what the optimal timing is for the utilization of radiation therapy. Now let's talk real briefly about oligoprogression. And so our group was one of the first groups that was thinking back in the early 2010s, could we add SBRT to patients that have now progressed, progressed on first-line therapy, systemic therapy, but not progressed everywhere, but in a limited number of sites. And when we added radiation in this single-arm phase 2 study, these patients had a PFS and an overall survival that was significantly better than patients historically who had been on this regimen who received no radiation. So it gave us some confidence to think that, okay, in this other sequencing scenario, that maybe the addition of local therapy may be beneficial. And again, what this study showed is that no longer were we seeing failures where we saw original disease, but only in distant sites of disease. And in fact, now that bottoms report, Astro 2021, is now a paper in Lancet by MSK physicians and by MSK. And it's now shown that there is a progression-free survival when we randomize in non-small cell lung cancer, when we randomize both patients without target mutations and even patients with target mutations. There's a PFS benefit by adding local therapy. So the jury is still out. We're moving and converging on identifying which patients are best going to benefit with radiation in the metastatic setting. But, we need to do better as a field. And what do I mean by that? We have all these studies. Some are showing a benefit, some are showing not a significant benefit. And as a field, we need to understand why we're seeing these different outcomes. And in part, and I think it goes back to the early studies and the differences in outcomes for individual patients in the systemic therapy only trials, there is a significant heterogeneity in patient populations that may be diluting this benefit. And so what do I mean by that? What do I mean is that if you look at this curve, and I drew this out, and that's why it's so squiggly, but if you take this axis and you start from the origin, and you say at that point in time, patients have oligometastatic disease, we're going to give them radiation. I cannot, unfortunately, predict for you which direction your disease is going to go because of such a heterogeneity we see in patient populations. We can't tell you if the disease is going to be controlled and you will not have any disease for 2 to 3 years. I can't tell you if after 6 months your disease is going to explode. Unfortunately, we don't have that predictive capability. And so that is the mission now of our program at Memorial Sloan Kettering, and I think others throughout the country and the world, is to start to better understand metastatic disease. And what do I mean by that? I want us to better understand metastatic disease as a function of their trajectory. That's longitudinal, meaning over time, as a function of therapy and as a function of tumor and host biology. So better integrate biology to understand the trajectory that metastatic patients have. And in doing so, we can personalize approaches that are more enriching for the likelihood of success in these clinical trials by identifying a synergy between the local and systemic therapies. So what our group is doing is we're trying to take large sets of data of patients who've already been treated, as well as patients who will be treated in prospective registries, and start to understand the biology and how treatments that are directed against the tumor reprogram the tumor and reprogram the host tissues to effectuate a specific type of metastatic trajectory. Meaning, we will want to understand whether some patients will met out widely after they start therapy and in what time frame versus which patients will not met out if you give them radiation. And the reason that this is all important is because we really want to bin patients into categories. We want to be able to better predict which patients should get local therapy and which ones should not get local therapy in the form of radiation. So if you look at this binning kind of simplistic binning strategy that we have, you have the two extremes. You have patients that are doing so well on systemic therapy that you don't even need to offer them radiation. And then you have patients who are doing so badly on systemic therapy, unfortunately, that radiation therapy will not matter. Then you have this large group in the middle who both have slightly poor prognoses or slightly good prognoses, but both sets of patients will benefit from local therapy. So we are using a multi-data approach to try to understand that. So in this slide here, in the left, it shows you patients with metastatic disease, and it shows you a bunch of data underneath that figure, a bunch of data that we collect: histopathology data, imaging data, genetic data, proteomic data. Dr. Das was talking about circulating tumor DNA type of data, so liquid biopsy data. We're collecting all of this data. And if a patient were not to get treated, it would be easy for us to follow these patients, collect that same data over time, and figure out when and in what frequency patients' metastatic disease distributes as a function of the disease biology. But guess what? Patients get treated. We need to treat patients. But every time we treat patients, we reprogram their tumors and we reprogram their host tissues. So what our group is doing is trying to develop an AI approach, or artificial intelligence approach. And what I mean by that is as following. At point number one, we are trying to annotate where and when patients' tumors progress as a function of their time, as a function of the biologic matrices that we collect, and as a function of therapy. Then what we're trying to do is we're going to try to collect all of this data and develop predictive and prognostic markers to tell me, for instance, if I get a patient that comes to my clinic and it has been referred to me by a medical oncologist and the patient has one metastatic site, it seems like a slam dunk that I would say, hey, let's radiate this one metastatic site so the patient can remain on the systemic therapy, because it looks like the systemic therapy has been working in 99% of the patient's body. But guess what? What if I were able to say that based on our predictive models, this patient is going to develop 16 more Mets in 3 months? Then it makes no sense for me to radiate that patient and put them through, whatever limited toxicity that we might put them through. However, if you send me a patient with 10 Mets, but I can say, hey, we're just in this situation with 10 Mets, but if we radiated those 10, the patient will have a progression-free survival interval of 3 years, then by all means, we should try to safely treat those 10 Mets. And this is what this model is really trying to enrich for. So in conclusion, I would argue that we need to keep doing these phase 2 and phase 3 clinical trials in the oligometastatic space, in the metastatic non-small cell lung cancer space, to understand when radiation will be or should be utilized. We need to prepare to debate ambiguous findings and use biology, longitudinal biology, to explain why some patients are responding and some are not responding. We need to develop these biomarkers that are predictive and prognostic of metastatic potential. We need to use and leverage large amounts of data in order to do this. And at the end of the day, we need to consider what is in the best interest of our patients, both with respect to quality of life and with respect to survival outcomes. And so we developed this practice patterns guidelines through different organizations, both on the North American side and Europe. But at the end of the day, I think the bottom 3 points are what's most important for our patients. Number one, I should have put number one, patient input is the most critical. How much they want to be treated, what they need to be treated, and when they want to be treated, and what's most important for them with respect to either quality of life or survival outcomes. And we need to leverage both. I think a multidisciplinary approach is important. And then I think we need to continue to understand what's going on in the setting of clinical trials to optimize our outcomes. And with that, I'll stop and be happy to take any questions. Thank you.
Dr. Iyengar, thank you so much. That was a really fascinating talk, and thinking about kind of what we should be looking towards in the future to really optimize the kind of local therapies in the context of our evolving systemic therapy landscape. And so we're welcoming Dr. Bajanova back as well. So Dr. Iyengar, one question for you. So I noticed in that trial that you had mentioned closed premature, didn't meet the endpoint that you wanted early. 0 to 3 sites were defined as oligometastatic disease. Do we have a consensus? Is there a site that you would not consider in the context of oligometastatic disease? Is there a number of tumors that is far exceeds in the absence of having those sharper tools with AI and other things?
Yeah, I mean, I think unfortunately, it was something I didn't point out, but in that slide with all the phase 2 studies, every single one used a numerical value for deciding what is oligometastatic. And numerical values are, unfortunately garbage, because what they represent is one snapshot in time, one cross-sectional snapshot of where the patient's disease trajectory is at. And we have no idea whether they're at the low part of the curve, the high part of the curve, they've plateaued out. So as you said, in the absence of better predictive models, we've as a field focused on 5 or fewer Mets to be oligometastatic. But there are studies out from Canada and other institutions in the United States where they're trying to push the envelope and say, in patients with 5 or 10 Mets, can we safely deliver SBRT? And if so, can we identify those patients that I was describing earlier that may have a large number of Mets, but that's because they plateaued out? And if we can safely treat them, they may actually have a benefit. And so, unfortunately, we're stuck with this numerical association right now, but hopefully in the future, we'll be able to change that.
And is the definition of what is an oligometastatic lesion constrained by SBRT feasibility or hypofractionated?
No, it's usually not. And to your other question, I'm sorry I didn't answer it. Whether it goes to the liver, bones, kidney, adrenal, contralateral lung, nodes, there's really no specific definition that we stay away from with respect to oligometastatic. The one thing that is important is that most data suggests that if you need to treat the primary lung cancer, the primary site of disease and the associated locally advanced nodal disease, if there is any. Because if you don't treat that and you just treat the mets, it's of no value.
And sorry to kind of flood you with questions, but we have one in the chat here that says, how can we learn from even what we consider perhaps a failed study, right? Is there an opportunity with LU's 0002 to identify a group of patients that might actually benefit?
And that's an amazing question. And I think as a field, we don't do enough of that. But the answer is absolutely yes. And now we've learned that it's not just enough for us to identify a phenotype from these trials. We need to collect patient samples, and we did collect patient samples. And so we are going to use some ctDNA assays to see if we could have predicted early on which patients were going to benefit long-term from local therapy and which ones were not. We're also going to collect imaging from all these patients and do some radiomics to see if, again, we could predict up front which patients would benefit or not. But we are desperately in search of a subset of patients that will have shown some improved signal. And what we can do is use that for future trials to enrich and optimize the likelihood of success.
And holding a couple of questions together for Dr. Bajanova. So we've talked about kind of in the earlier segment, biomarker testing, right? Next generation sequencing to help kind of elucidate who might benefit from a targeted therapy. Where do things stand with respect to antibody drug conjugates? Can we kind of learn anything from our next generation sequencing? And then to tack on a second question that might be semi-related, someone in the audience astutely noted that we've seen a bunch of press releases of failed studies in comparison to docetaxel. How do we move the field forward? Any insights as to why are not, perhaps strategy, study design, et cetera, why those studies may not have been successful?
Yeah, so docetaxel has been our nemesis. We hate it with a passion because it does have pretty significant toxicity. We are really working hard and find something better, but so far everything kind of fails over the docetaxel. I think, it's hard to understand why antibody drug conjugates over docetaxel trials, at least the recent press release of CCAM trial, and were negative. I think the question is, should we be using the biomarker targeted strategy, right? So technically we are developing antibody against TROP2, right? Why are we not testing the patients for TROP2? And there is a reason why we are not, is we've done that, and we saw that you see responses pretty much regardless of the TROP2 expression. And so maybe TROP2 is not the right biomarker. Maybe it's a biomarker of how good the ADCs are being engulfed by the cancer cells. It's actually also interesting for the DATA-DXd, which is datopotamab deruxtecan, the recent release of the second line troponin, I forgot the number, I think it's 05 study. They showed that there is a different improvement in non-squamous non-small cell lung cancer, but lack of benefit in squam. What to make out of that, it's really, we don't know. There was a question about, can we use next generation sequencing to decide which patients will benefit from antibody drug conjugate and which of them will not? I think it's a little bit too early because yes, you can find the TROP2 overexpression by RNA, but the studies were not designed to test the strategy, and we can certainly do that. I still, honestly, even though the randomized studies against docetaxel didn't show what I wanted to see, to me, I still find the value in antibody drug conjugates because it gives me an extra treatment option. even if I give patients docetaxel, the median progression-free survival in second line is 4 months. So what am I going to do afterwards? And give gemcitabine, and the median PFS is like 3 months. So it's like the more treatment I have in my bucket, then I think honestly I'll be a little bit better off. And then toxicities are certainly slightly different as well between those two, and maybe you can win on toxicities in a way.
You said two things. The first one I wanted to kind of spend some time on, right? So with targeted therapies, for the most part, they tend to be a little bit generally tolerated, better tolerated than our traditional chemotherapies. Here we're kind of merging two types of therapies, and we're having to get comfortable with different types of toxicities like we did with immunotherapy. And so I wanted to spend a moment in thinking about, in talking specifically stating some of the unique toxicities that we see with these bispecifics and these antibody drug conjugates. And also, as part of that conversation, focus a little bit on that hypersensitivity reaction. When do we expect it? Is it something that should make doctors practicing in the community, patients pause and kind of not push forward with the therapy?
So I'll take the last part of your question first, the infusion reactions. Remember, those are proteins, right? So both antibody drug conjugates as well as bispecifics are proteins. So the patients will react to the foreign proteins. The reactions are generally fairly mild. Like, for example, amivantamab, we have to separate the day one in 2 doses, give a little bit of the chemo treatment first, and then you give complete the full dose on second. It's very similar in management like what we see with Rituxan, sometimes with cetuximab. So the infusion reactions are generally not bothering me. The other toxicities that you mentioned, I certainly can be difficult to manage. Like, for example, the CCAM antibody drug conjugates have mucositis. Some sacituzumab has mucositis as well. And mucositis are very uncomfortable for our patients. It's painful. You have to minimize what you eat and what kind of quality of food you take. And there is not a good of treatment options for us to manage the mucositis. And then another example is pneumonitis, for example, with the trastuzumab deruxtecan, the HER2 antibody drug conjugate. The rate of pneumonitis is pretty high. It's about 14-15% in the most recent studies. And we know how to manage pneumonitis in general. But, the patient developed pneumonitis, especially if they develop more severe pneumonitis, that means that the drug is not going to be able to be given to them afterwards. And at this point, we really don't have any idea which of those patients will develop pneumonitis upfront. We haven't been able to identify the specific characteristic of the patient that will tell me, okay, this patient is going to develop pneumonitis and this patient will not.
I think we need Dr. Iyengar's tools, right? I think we need to be just as precise in our kind of prediction of efficacy as we are with toxicity, right? I think a lot of our focus has really been on efficacy. And
Yes.
to pivot a little bit to brain mets. And so I noticed in the kind of NRG study, it was looking at extracranial metastases. And so questions for each of you with respect to brain metastases. How do we think about focal therapy versus whole brain therapy for radiation in the context of brain mets? Are there too many lesions? Is there a threshold that you tend to think of? And the second for Dr. Bajanova to think about while Dr. Iyengar is answering is, how do these new therapies work in the brain? So our antibody drug conjugates, our bispecifics, do we know anything about their efficacy in penetrating the blood-brain barrier?
So I'll take the first question. And I think that it's really amazing. We have moved so far away from whole brain radiation therapy now. And it's because SRS has become so commonplace. Our stereotactic radiosurgery, which is the SBRT of the brain, has become so commonplace. It's so effective. It's so easy for patients. They can be one-day episodic treatment, and they do really well. And what we've really moved away from is also rushing to treat the brain in terms of METs, because of what you just described as the second part, which is that systemic therapies are getting better and better at controlling intracranial disease. And so, number one, we shy away from rushing in if the patients are asymptomatic and they're getting a TKI or perhaps some immunotherapy. Number two, the question of, is there a cutoff? My personal experience in group, if there are 20 or more METs, 15 or more METs, I offer whole brain. And if there's fewer, I don't. but I've had colleagues who have treated 30, 40, 50 over some time. But, you know, I don't know what the right answer is for that. There are studies that are looking at all of these questions through the cooperative groups and as single institutions, but it's certainly a fascinating area to explore.
Right, and I'll take the second question. So as you correctly kind of alluded to, remember when I started talking about antibody drug conjugate, one of my statements was that this is a very large molecule that is not able to penetrate inside the cancer cell. So initially we were always very worried about our ability to result in CNS response. But recently we have two data sets, one from pertuzumab deruxtecan, which is a HER3 antibody drug conjugate, and another one from the HER2 antibody drug conjugate, that it does have intracranial overall response rate. I think HER3 ADC, the intracranial response rate was 33%, which is, you know, I think in my opinion is pretty good. Why and how, I don't think we understand fully. Could it be that, you know, that chemotherapy molecule that gets released gets into the brain? Could it be the fact that if the patient have tumors in the brain, your blood-brain barrier is not perfect, and maybe it's damaged enough for the antibody drug conjugates to penetrate? We don't know that for sure, but it's encouraging that we definitely see responses in CNS. I will be honestly, like what Dr. Yanhar said, I'm very comfortable delaying radiation for the TKIs because the efficacy is 80% response rate, 60% complete response rate. I'm a little bit weary in delaying radiation for the antibody drug conjugates just because we don't have a lot of experience. So this is going to be a little bit more of a discussion with the radiation oncologist, and also depending on where exactly those brain mets are. I'll be talking about brainstem, where even like a little growth will mean a lot of side effects for the patients versus like tiny lesion in the periphery, and I can try. But I'm just kind of personally a little bit more apprehensive, if you may, in just delaying radiation for the antibody drug conjugates.
Yeah, I think my practice is quite comparable, and I think it was really a pleasant surprise to see activity of the ADCs. And so we're pivoting to the question and answer session. And so the first one is for Dr. Das, and I'm going to read it verbatim. It's just a member of the audience has written in. I was told that it isn't ethical for advanced stage patients to get placebo. In what cases are these advanced stage patients considered for placebo? And in the case where placebo is the better option for an advanced stage patient, are these patients remaining on a current therapy, or are they possibly receiving no therapy at all? So getting to the question of placebo control trials.
Yeah, I think it's a great question. I think there's been a lot of editorials and controversies that have come up, you know, kind of regarding this and whether crossover is allowed in these phase 3 randomized trials. So, you know, I think the broad answer to this is that we really don't want to get into a situation where we're not offering the patient standard of care. And I think part of it depends on where you are in the world and what is considered standard of care, where this trial is being conducted. But I do think that, you know, now for most patients with advanced metastatic disease who do not have a targetable mutation, the standard of care is considered to be chemotherapy plus immunotherapy. And so that should be this, you know, sort of the non-experimental arm. And I think, again, it depends on the setting. So if you're thinking about perioperative treatment now, so we have a number of FDA-approved options and in the perioperative space. So I think it just depends on the setting, metastatic versus early stage. What is the sort of current standard of care? And we do have to offer that to patients. And I do think there's been controversy about the, you know, kind of the allowance of crossover. So for patients who are randomized to placebo, are they able to go on to get the experimental treatment? And I think it differs according to the trial. And again, kind of depends on where the trial is being conducted.
And that add something, because I think this is very important question. And as a practicing clinical trialist, I do clinical trials for a living. This is a very common question we get from the patients. And I think the reason why this question is being raised is when we say the word placebo, in majority of our trials, especially in advanced disease, first or second line, or even a third line, patients are not just getting placebo. Like, for example, Dr. Das, when she was discussing neoadjuvant trial, even though there was a placebo, but it was placebo with chemotherapy. So the randomization is chemo plus immunotherapy, and a second line will just get the chemo. And the question is immunotherapy adding something to that or not? If you have a first line stage 4 trial, the randomization could be platinum doublet, which is an effective therapy, versus plus placebo versus platinum doublet plus immunotherapy. In the United States, I have not seen a pure placebo trials for decades. And I think, in my opinion, it would be reasonable to run a placebo trial, maybe fourth line of therapy with prescribed crossover design, because I think that's very, very important.
And so the next question is for Dr. Yang. Are there any specific health conditions or factors that could impact the surgery?
Yes, so I think that for folks who have heart disease or their heart is not as strong, that oftentimes we have to make sure we talk with the cardiologist and do any testing that is necessary to make sure that they can tolerate actual operation. So one of the things I didn't quite understand, perhaps as a medical student, was that the heart basically goes through a big workout when you're under anesthesia and during an operation. And so it's important that, so I've had patients where we weren't sure how well their heart would do, and so wanted to get the cardiologist to weigh in, and then the patient ended up getting additional treatments, like having a stent in their heart, and then on some anticoagulation antiplatelet medication before they could start surgery. The other component are the lungs. That's a big component as well. And so for folks who have lung function that is not that good, or have diseases like interstitial lung disease, we're really, really careful about making sure it's safe to do surgery. And so for all of my patients, I try to have them do some type of pulmonary rehab or exercise or preparation for these operations. And then certainly if they have more severe lung disease, like interstitial lung disease, we work very closely with the pulmonologist, which is a lung medicine doctor.
Perfect. And then there's one here about, I think we already partially answered this. So bispecific antibodies are newer therapy. Is there an approved one? Dr. Pajanova had mentioned amivantamab is the one that we have currently. And then we talked a little bit about the safety already. And so we'll move on from that one. There are many questions on radiation, Dr. Iyengar.
No, shocking.
Yeah, the fan favorite here, so it's great. And so I guess one is average length of radiation treatment for patients with stage 4 lung cancer.
Very, very important question. The NCI, when we did all these trials, they really wanted us to limit the time that radiation took in order for us to not delay patients going from their induction systemic therapy into their maintenance. So SBRT can take, literally, it can be a 1 fraction treatment in 1 day. So we don't really delay systemic therapy. The timings where things are a little bit trickier is that when we have to treat the primary disease in the mediastinal lymph nodes, and if it's all packed in, we can't really use SBRT. So we have to use what we call a hypofractionated approach, which is between SBRT and a more conventional treatment. That takes 2 to 3 weeks. And so that means that most of the time there will be probably a month delay between the induction and the systemic therapy maintenance. But if the maintenance or systemic therapy is every 2-3 weeks, we try to fit it in between.
Perfect. And there's a quick question here about, is it possible for gamma knife for C3 versus
for C3, yeah. So C3 is a little bit low when we try to do intracranial and upper spine disease treatments. But you can certainly use any basic linear accelerator would be able to treat C3 Mets with SBRT.
Perfect. And then we'll move on to other non-radiation and come back to radiation after this next one. But I think this is a very insightful question. So how will my oncologist know if I'm a candidate for radiation therapy? And I think as an oncologist, I'll humbly say that I ask my radiation colleagues a lot of the time as well. I think that's one of the advantages for you, right? We work in multidisciplinary groups. We have very close relationships, right? And so I never give a definitive answer about something, especially if a patient is particularly interested in radiation. I think it's best to speak with a specialist in that area.
Yeah, and I will say that, you know, there are a lot of our community-based our patients who are going to community-based practices where they don't have the benefit of a multidisciplinary approach. And what I would say is that it really comes down to the medical oncologist who's following you. And if they think that you have benefited tremendously from a systemic therapy, and there are some limited number of lesions that if we're treated, they could keep you on that same systemic therapy. As Dr. Basanova said, there's unfortunately diminishing returns with every subsequent line of systemic therapy, then you should ask your medical oncologist to refer you to a radiation oncologist for that question, as Dr. Dagojak pointed out. And I think that's really the best approach.
Perfect. And so the next question is for either Dr. Bajanova or Dr. Das or both. After someone has completed neoadjuvant chemotherapy, what is the monitoring afterwards? And I think Dr. Yang briefly touched on some of this. So perhaps we can have Dr. Das.
Yeah, I mean, I think that the trials have asked for the surgery to be done within a 6-week time frame after neoadjuvant treatment. So typically around, we want patients to be fully recovered from their neoadjuvant treatment, and then, you know, within 6 weeks undergo surgery.
And then if someone finishes this, so you've had your perioperative or either purely neoadjuvant therapy, you go to surgery. After surgery, what comes next, right? Who does the patient follow up with? What is the expectation as far as surveillance? How do we make sure the cancer hasn't come back?
Yeah, well, the patients generally will follow up with both their surgeon and also their medical oncologist, and to review the final pathology from this surgery, in order to make some of the decisions about what additional adjuvant treatment should be offered. And this is a very, very tricky area, because I think we're still trying to understand, based upon pathologic response to the neoadjuvant treatment, whether patients should go on to receive additional therapy. Part of it does depend, again, on response to the neoadjuvant treatment, whether or not they have a driver mutation, things like that. And so I think the follow with both the surgeon and the medical oncologist is crucial. Sometimes these patients are re-reviewed at the multidisciplinary tumor board to really discuss the best adjuvant treatment. So there are some patients who may be offered postoperative radiation, depending again on what's found at the time of surgery.
And sticking with the recovery space, this one was specifically posed to Dr. Yang. What can I expect in terms of pain and discomfort during the recovery period? How will my recovery be monitored, and what tests or imaging, we talked about this part, during follow-up appointments, and what are the potential complications that can arise during or after surgery?
Yes, so in terms of pain and discomfort, I think that with good pain medicine, the pain and discomfort usually can be around 3 out of 10. So 10 being the worst pain of your life, 1 being no pain. I think that we can usually get patients at around 3 immediately after the operation. And then probably after about a couple weeks later, I would say a lot of patients no longer have any pain, but some might have still some discomfort, and then eventually it goes away. I always like to tell patients that their pain actually, without medication, their pain will go up the first few weeks because they become more active. And so it's totally fine to take more pain medicine during that period of time. And we really try to stay on top of pain because we want patients to feel very comfortable. And I have noticed that people who worry a lot tend to need more pain medicine, and that's also normal. Let's see, in terms of the second question,
The recovery, the complications kind of acutely and kind of more long-term.
Okay, yeah, so I think the most common complication is prolonged air leak. So when you have anytime you do lung surgery, your lung can get irritated and it can leak air, or and that usually just stops on its own. It usually seals up after a day. But sometimes for some patients, it takes a while. And so in that case, you'd have to have a chest tube for longer than 5 to 7 days. That doesn't happen that often. At our institution, it happens about 5% of the time. And I think other types of complications are very similar to the complications of any kind of surgery. So things like having clots to the lungs, having a heart attack, and things like that. But those are thankfully in this day and age very rare. And then the last thing I think you had asked was about the tests and imaging that are performed during follow-up. For stage 1 lung cancer, we usually just do a CT scan of the chest every 6 months. And for higher risk patients, for higher stages, we'll often add a brain MRI to that.
Perfect. And then the next two are for Dr. Bajanova. We'll compile them or combine them. The first question that was asked is, what are the potential costs associated with antibody drug conjugate treatment? Is it covered by insurance? And the second, I think that you tackled part already, is what are the side effects of antibody drug conjugate treatment, and is there a way to prevent or treat them?
So the only antibody drug conjugate that's currently FDA approved is covered by the insurance. It's trastuzumab deruxtecan, currently approved for patients with stage 4 lung cancer and a specific mutation in HER2 called HER2 exon 20 insertion. The other antibody drug conjugates are not FDA approved. Some of them are not even prescribable because they are not approved for any indication. And those, of course, they will not be able to be covered by your insurance, but you might have an access to those antibody drug conjugates if you participate in clinical trials. The second question was about the side effects. The main side effects of ADCs, there are what I call the chemotherapy-like side effects, which is a nausea, which we can prevent and treat with antiemetics, anti-nausea medications given before chemotherapy, as well as sending you home with some anti-nausea pills. The second side effects like keratitis and mucositis, it is hard to prevent, but we can treat. And the same thing with pneumonitis, also hard to prevent because we just don't know who gets it upfront, but it is treatable. And usually treatment for pneumonitis means holding the drug and giving steroids, and steroids will decrease an inflammation that the medication caused of your lungs.
Perfect. So Dr. Iyengar, the next two. Are there locations where METs are better targeted with radiation? And then how do you measure the success of radiation?
I'm going to be biased, and I'll say that if we can deliver appropriate dose, we can control disease in any part of the body, but that dose is limited by the normal tissues that surround that site. I would say for oligometastatic lung and the patterns of failure, we do a good job of managing control with SBRT when we need to treat in an oligometastatic fashion. But I will not, downplay toxicity. Toxicity is a very significant issue. It's going to become even more so as more patients receive immunotherapy, as they receive ADCs and bispecifics, and as we start thinking about patients longitudinally living longer, having chronic disease, and we having to come back repeatedly in a sequential fashion to radiate their lungs for new sites of disease. And so, I think the most complicated, scenarios are pneumonitis. Even though, I think we have a handle on it, there are some patients that develop a refractory pneumonitis. We have to have them on long-term steroids of high doses. And even then, their baselines are never the same again. So I think pneumonitis is a very significant toxicity. Esophagitis is something we can manage and we're careful about. Any injuries, neurologic injuries are something not to be taken lightly. The brachial plexus is a set of nerves that come from the neck down the arms, and we often are having to radiate and re-irradiate areas in the neck, and even looking at other nerve areas. So there are side effects, but as long as we use our appropriate thresholds and approaches, we can limit the toxicity. But I would say pneumonitis going forward could become the type of toxicity that limits patients receiving further systemic or local therapies. And to me, that's the most crucial thing to kind of control and manage.
Perfect. And then just very briefly, does anyone have any familiarity with specific dietary or lifestyle recommendations during chemotherapy? I think this is a field that's very much growing right now. I would just say in my clinical practice, my goal is to maintain weight. do what we can to maintain weight rather than kind of depriving certain nutrients, et cetera.
Well,
I
you know,
don't
I study cachexia, and so I mean, I'm very cognizant of nutritional studies, and that's the first thing every one of our patients asks. While I'm going through therapy, what can I eat to optimize both my quality of life as well as outcomes? And we haven't done the right randomized studies and appropriate studies to answer those questions. But for me, as long as what you said, nutrition is very important in terms of calorie maintenance to maintain weight. And so as long as they're maintaining weight, that's probably our best metric of whether they're going to have a decrement in outcomes or not. So I tell them, eat whatever you want to eat. If you like pizza, eat that all the time. It's not the time to worry about broccoli, but you know, maybe I shouldn't say that too loudly, but I think that's the approach I would take, or I do take with my patients.
Excellent. And we will end kind of, I think, a highly relevant question here. So are there resources for connecting with support groups or counseling services? And I think kind of the mission of Grace, as we're presenting here, is to bringing you that information in a digestible format. But I also recognize that everyone digests and kind of processes information in different ways. Some of us turn to peers who are kind of sharing the same experiences. If you have a diagnosis, others want to like turn to articles, etc. And so there are, I think, I don't have the best answer for this, but there are multiple patient groups. So if you have a particular driver alteration, there are groups that have been formed. EGFR has one, ALK has one. There's programming put on by Grace, Longevity, and others as well. I think just asking your doctor and also asking the social worker. There are also kind of cancer center and kind of practice-specific support groups that are available, and also some in communities too. I've had patients who really derive significant benefit from just reaching out locally to saying, who else? It may not be my exact type of cancer, but who else is suffering from cancer in my neighborhood? And going online and finding that and kind of having a buddy system or mentoring system.
I'll just add to that. I think there's a recognition that, you know, taking care of a patient is really it takes a village. It takes, you know, we talked a lot about the multidisciplinary, you know, kind of care team, but this, of course, also includes psychologists, palliative care specialists, and it's really nice to have all of these members of the care team being part. You know, at the VA recently, we have now integrated palliative care into some of our clinics, which is great. To have a palliative care specialist there with you when, you know, the medical oncologist is going to see the patient. I think that's, of course, the goal, and it depends on where you're getting your care. But I think regardless of whether you can get it at the time that you're being seen in medical oncology clinic, there's referrals for you know, psych onc, for palliative care, lots of different services. A lot of this is also through social work.
Exactly. And I think don't be shy or afraid to ask for help or additional resources. And so thank you so much to our panelists, for our speakers today. Thank you so much for having kind of a vibrant audience that kind of provided a lot of questions for us to kind of mull over and provide answers for. I apologize that we couldn't get to one or two questions, but I hope that everyone learned something today, and feel free to kind of give us feedback as to how we can improve Grace programming moving forward. And I hope everyone has a great rest of your day, your night, your morning, wherever you are. Thanks for joining.
Great, thank you.